Yeah. Okay, for our October session, we've set up a couple of great presentations for you. We'll look first at a little bit of a extension of what we've discussed before in terms of the metaverse and looking at specifically to healthcare applications in AR and VR. And our leader in the presentation will be John E Avocado, Sales Director for OmniLife VR. On Johnny.
Good morning. All right, gentlemen and ladies, how are you? How is everybody today? Kind of dreary out today, so I decided I better wear something, perky to keep us all with our attention, or something better than all that rainy weather out there if you're in the Kansas City area. So let me go ahead and see if I can't share my screen. So everybody's seeing that, all right?
Yes.
Okay. So how many folks here have dealt with virtual reality very much? All right, there's a couple of us out here, right? So virtual reality is something that we've been working on as an industry, as even, a group of scientists and technologists for a long time now. Some of the first records of what virtual reality, we were trying to use it in the commercial space, was after World War I, the Navy developed a very noteworthy project called the Artemis Project. And now this project was, the goal of this project was to start to identify and treat shell shock in the victims of the trench wars. And what they began to use was some very rudimentary, mechanically driven simulators that allowed bombardiers and people that were in the trenches to relive a simulacrum through a very complicated goggle system. And it was one of the very first inroads that we had where we were attempting to try to create an interface with the mind through technology that we had control of all of that situation. So from that project became some of the knowledge, some of the technology that we actually use today, everything from that headset and how the ocular begins to work, to the outside information that we take in, which we begin to use the term haptic now, how we can instigate somebody's the feeling and the sensation that you have as if the world around you is pushing back on you in the virtual world. A lot of that technology began with that first Artemis project. Now, even before that, we have, as a society, been working to understand how the mind works. And much of what we do in virtual reality in the medical space absolutely has to do with how the mind works. So I'm going to start with that. Long ago, when we were tribesmen, one of the first things we began to do is tell each other stories so that we could begin to share information and to put one another into a different state of mind. Now we know historically that there's evidence that that as a species, we would go on vision quests. We would attempt to alter our state of mind. We would be given a driving psychological story, and we would be put through an experience that was altered from the world around us, all in an attempt to give us new information and to help us be able to assume that information. So that's a lot of what virtual reality really is, even to this day, is a methodology for us to tell a story directly into the brain and to get rid of a whole lot of the outside information. And so I'm going to talk about how that process is really refined and defined in virtual reality, and how we at OmniLife Virtual Reality use that through the commercial space so that we can make effect. I'm going to tell you just a little bit about OmniLife VR first. So OmniLife VR was founded by our founder, Marco Stanich, there that you can see. He started off, his claim to fame is that he started off in the worst phone store when the phone industry, the cellular phone industry began, and became the top salesman in the nation before it was all over. He wound up moving here to Kansas City and starting a company where he had his own phone stores, and he had about 9 or 12 stores in the area before it was over. As the cellular phone industry began to change, he recognized that virtual reality was on the forefront and he wanted to get in on it. Well, now he and his boys were gamers at the time, of course. They really enjoyed technology. And what he discovered is that there was not a safe place for his boys to play virtual gaming online. So he started his first virtual gaming company called Disciples of Gaming to create a safe space for his boys to be able to interact and use this technology and play online. Now, we are a faith-based, family-operated organization, and our mission continues to do so, keep this centered around that. When he decided he was going to move into the medical space, he started the company OmniLife VR. OmniLife VR's mission is to recognize that virtual reality can be used for a greater purpose than just entertainment. That entertainment, that storytelling element is just the beginning of how we use that in a more worthwhile way. So we began with that safe space and continue to do that as OmniLife VR has continued to evolve. Now, OmniLife VR, there's three main spaces that we work in the medical space. The first one is mental health. Now, mental health is that component that we have approached at the beginning. As a company, there's a couple of things that were very dear to us when we began to make our outreaches into virtual reality. And one of them is our veterans. The very same program, the Artemis program that was centered around that, was very near and dear to us. And so the veterans of our world today have so many of the problems that virtual reality really can begin to make inroads on. So they are a prime client for us and somebody that we knew we could really take care of. And one of those first components for them was that mental health aspect. PTSD was a problem that virtual reality has been working to solve for a long time. And it's only begun to be in the last few years that we've really begun to make those inroads. OmniLife VR started working with a gentleman by the name of Skip Rizzo, some of you may know, who started the Brave Mind Project. And now from that Brave Mind Project, which is probably the most modern, recognized initiative for PTSD symptomatic recovery. We now refer to this as in very different forms, but we still work on the same process of trying to solve the problem of trauma. So now what started off as a PTSD has escalated within the industry to cover so much more trauma, everything from fear of heights to fire, to bugs, to cleanliness, to open spaces, to crowded spaces. The list goes on and on. So the way that we were able to do this, I'll explain to this in a minute, is the way, because of the mechanism which virtual reality works with your interface of the mind. Now, because we have such control over your mind, and I'll get into that in a minute, when we put you into a virtual reality simulacrum, we're able to really affect your physical health. Now, one of the things that we need to do in the physical health space is that we need to be motivated to perform. Now, there's so many obstacles that virtual reality therapy in the physical health space help us overcome. Now, it's not just making you want to come and do this. There's a number of performance modifiers that really occur with how we retain information, how we develop muscle memory, and the state of mind that we need to be in, the activity that we're processing, and the cognitive ability. All are some of those methodologies that begin to understand how we encode memories and how those memories begin to be saved from throughout the day and into the late night, so we can keep those information in long term. Now, I start to talk about that because that is really some of the foundational places that we began to work at OmniLife in the aging space is dementia and Alzheimer's. Now, early on, we're about a 10-year-old company. Early on, we did a whole lot of research with some companies or in some of the organizations here in Kansas City. We worked to try to see what we could do about dementia, concussions, and Alzheimer's. And what we really found was pretty profound. The ability for the brain, as we all know, the plasticity of the mind to repair damage, whether we're able to teach somebody to walk again in a new way who's missing a limb, or to begin to have a new thought process after there's been, physical damage to the brain, and we can extend that into the mental health, where we can work around scar tissue and create a new level of psychological wellness around a trauma instance. So I talk about all those things because the third thing then is the holistic, and how OmniLife Virtual Reality uses VR to do the holistic approach to healthcare that many of us are beginning to migrate toward. We recognize that you can't just solve a singular or insular issue with someone. There's much to someone's diagnosis and the entire process of wellness to get them back to a good place. So when we talk about virtual reality and we begin to speak about the elderly and the aging, there's a great deal of how the mechanics of virtual reality work, which I will get into, that really stimulate our ability to retain memories, to work within our recognition of where we are in space, our spatial orientation, our ability to keep track of time. And then, of course, there are a lot of social interactions that we're able to induce through virtual reality that we can train and teach that we wouldn't normally get in our daily activities. Now, much about how we know, like any muscle, the brain has to be used for us to not lose that information. When we begin to talk about holistic wellness, especially within the age group, we're going to talk about how virtual reality can stimulate and regrow and reconnect those neural connections to old memories. So I want to start off first off with mental wellness. I'm glad there's a couple of folks in here that even work in the biospace, because that is where we've come to understand with mental wellness. Virtual reality goggles and headsets, if you may not know, have the ability to look inward at you. What we're doing is we're tracking your eye. We need to see where your eye is so that we can keep things in focus. Now, that mechanic early on was harnessed within the industry. If we understand how people's eyes open and close and dilate, we can begin to see the inflammation of the capillaries in your eyes. We can look with infrared and see how flushed your skin is. We can capture your temperature, and there's a whole lot of other things that we can do just with the standard as is out of the box headset. Now, when we decided that we were going to come into this space, that we needed to develop a program that was worthwhile and comprehensive across the industry. As we began to start to look to develop for ourselves, we recognized that there was a partner that we could work with in Europe, and it's a company called SciTech. And so we've partnered with SciTech to bring to the United States SciTech technology, which is a software suite of virtual reality therapy training for trauma. Now, the great thing about this is that, of course, it spans over 300 or so trauma experiences, and it does not require a clinician to walk somebody through most of those experiences. We also use AI within that space to create a safe zone somebody can always come back to. But the really revolutionary thing about what we're doing with SciTech is that they've taken our ability to take that bio data one step farther, and they've developed an interface that actually touches up against the skin. And now, of course, as we know, there's a lot more biometric feedback that we can begin to get once we actually have contact with the skin. Just like, almost like an electric tongue, we can begin to see what some of those chemicals and whatnot that you're producing on your face, and we can start to take some readings from that. So in the physical or in the mental health space, OmniLife Virtual Reality brings primarily SciTech and a bunch of other programs. We also offer access to the Brave Mind project. That's something that somebody can get with us to get to. But mostly what we do is we'll come into in the mental wealth space is we'll bring SciTech technology, both the software and the equipment, to a clinic so that they can use it with their patient and their in-house and then outpatient as well. Some of that is designed to go home with the client. Now, the next big space that we work in is physical health. Physical health is important to us because much of our clientele actually was within that aging space or within the recovery space. And so in the aging space particularly, balance was a problem that we recognized their industry needed to solve. So many accidents happen within the clinical space of people who are sedentary or who are often bedbound and not ambulatory. Suddenly they have to get up and use the restroom, or suddenly you have to move them from one space to another, and you rely on them to be able to locomote themselves. What winds up happening is that they will lose their balance, and because they haven't used their muscles in a while, they can't recover and they'll fall, oftentimes injuring themselves and sometimes their caregiver in the process. Now, any of us that work in the aging space recognize and understand that that's a flag within the insurance industry. As soon as somebody falls, we can calculate and know by the rest of the diagnosis that they have how much longer it's going to be before they need to fill that bed at an aging facility. Now, we at OmniLife decided that we really wanted to come in and make a difference. And so we decided that we wanted to trash this industry standard of marking the day of your death once you've fallen. And so what we have done is we've partnered with a company called Corpus VR. Now, Corpus VR is, of course, another company out of Europe. And the reason I'll get to that if anyone wants in the question sections a little bit about why we're able to do so much more in European theater than we are over here in America. Many of you already working in this industry could probably recognize what some of those things are. But so we import a few technologies to include Corpus VR for the physical health space. Now, Corpus VR, we brought it in as a partner, most particularly for that balancing. It really helps those that are in the aging space develop the balance that they need, so that when they do have to get up and move around, they won't hurt themselves, their caregivers, or their family. And we can break that industry standard of filling the bed. Now, we don't just talk about the balance within the physical health space. There's all sorts of things that we need to do from recovery in the health space. There's a lot of surgery, right? So recovery from surgery is much of what the Corpus VR is about. If somebody has rotator cuff surgery or has had some sort of other a hip replacement or something like that, we're able to help somebody recover from that. Now, virtual reality works really well on the performance sector within physical health space. People have buy-in. They really want to do virtual reality. It's fun, it's gamified, and you don't pay attention to what's going on. Now, distraction therapy is something that virtual reality has used for a long time within, especially some of you may understand what that is a little bit, where we defer you from the pain. Now, that works really great in pain clinics where we're trying to change, say, the bandages on a burn victim, one of the most painful things that we can do. With diversion therapy, we can displace that pain from somebody and they don't feel it near as much. And there's a lot of evidence about what we've done with a doctor called Dr. Leon Probascus, who unfortunately had a stroke not too long ago, was no longer with us. But for about 3 years, he was using our equipment in his lab or in his clinic. And what he was doing is he was changing the bandages on these burn victims. And the distraction of virtual reality was what he was using to defer their pain. Now, Corpus VR, the physical therapy that we use out of the Netherlands, is very similar process and thought to that. What we do is we talk about pain deference, yes. So, or pain anticipation. In normal physical therapy, if you've ever had physical therapy yourself, or if you are a physical therapist, you can recognize and see that they spend so much time trying to look into the face of the client to see if they're hurting someone as they push them to their limit. Because oftentimes we don't want to innately do this on our own. Much of that has to do with this concept of pain anticipation. When I'm working in the physical space, I will work up to the point of where I think there's pain, and then I'll quit working. So when we have somebody in the physical world and they can recognize and see where their stop points are, they will anticipate that pain and not perform to the full 100% of their movement that they could. When we put them in virtual reality, they are distracted from necessarily the total location of their body, and they're also distracted by the exercise that they're doing. So they have deference from this pain anticipation. So they will work right up to the point of pain. And when their body signals to them that they're in pain, they reduce, recover, and come back. So we can get somebody to perform at a much higher degree through physical therapy, through the buy-in, through the gamification, and through the anticipation of pain deference, because they will work right up to that point. There's a lot of evidence that we have about that for 3 years, they had a study with Corpus VR in the hospitals recovering from whiplash recovery. And I could bring some of those numbers around later for somebody who wanted to sit in on a demo, but it's absolutely ridiculous. Some of the recovery that they got, the buy-in and the end result of how many people finish their regimen to completion compared to what we get in the United States is pretty ridiculous. So that's what we do in the physical health space. Now, the third space that I want to talk about here is actually sports training. Now, this kind of rubs up against all of this. And I'm going to talk about sports training for just a minute because it talks about all the other things that we really kind of tie together in virtual reality. Now, the best example that I can give of how we retrain the mind using virtual reality in the physical sense is that we could put a boy or a girl out on a soccer field and give them a soccer ball and tell them to kick the ball for an hour. In that hour, they might kick that ball 30 times and they'll run all over the field. They'll be distracted by all their friends and they'll see all sorts of sensory input that is part of that process. If we put that same person into virtual reality, not only will they kick that ball 120 times, the only thing they're going to do is kick that ball. They'll take the 5 or 6 steps up to kicking that ball and they'll kick that ball. And so what we have is we have iteration over time, so that makes it stand out in the mind more. The next thing that we have is that we pair that with cognitive recognition. So we make them work mentally. The individual has to work within the space and use their mind to recognize what the goal is, where they need to kick the ball, how they need to kick the ball. So we induce that cognitive ability. And then the third thing, of course, that we're doing is we're forcing them to move physically. When you move physically, that ties in closer to how the memory is made and what it keeps. So when we put those big blocks of information, that's all the same thing, that ties in with the correct mental state, that has the correct physical attribute, has the right cognitive induction, then those memory blocks are saved and stored by the mind much more easily than they would be otherwise. And this is kind of the behest of how we even use what we do in virtual reality for the next thing I want to talk about, which is holistic wellness, especially within the aging space. Now, I talked a little bit earlier about Dr. Leon Probascus. Now, Dr. Leon Probascus, what he was doing in his pain clinic is that he had those the burn victims. He would change their bandages. Now, he discovered that at first he tried to find particular virtual reality experiences that somebody would really key into and that would work for them. But he began to discover that just the virtual reality itself as a technology, as long as it had some key indicators, really did work to defer from the pain. He also discovered that the trauma of the pain itself is trauma all on its own, right? So anticipation of this trauma is something that he had to deal with. So through virtual reality and through some wellness exercises, he was able to condition somebody before they entered their trauma. And he also began to recognize, even no matter how well prepared you have somebody for trauma, they're prepared for the trauma, they go through the trauma, you still have to come down from it. He began to recognize that he could use virtual reality to bring somebody down from the post trauma as well. So Leon Probascus used virtual reality to condition, to divert, and then to post process somebody's trauma. And that was pretty important to us because there's so many spaces in the medical field where we know people have to anticipate pain, have to anticipate discomfort, and have to anticipate that trauma. And so everything from dialysis to chemotherapy to the list goes on. You can see that more and more than I do. Now, we also know that what we have to do is we have to tie all of those things together, as I spoke of at the beginning, that it's not just the mind, it's not just the body, it's also the spirit. And from the beginning of when I began to talk to you, we talked about how we tell a story to one another. And that's really how we begin to induce the different psychological states of wellness within our mind, is through that storytelling. And with virtual reality, we have you absolutely captured. We remove all of the distraction. The only thing you have to focus on is the information that we give to you. You still create the same number of neural connections, but it's only to the information that you have in front of you. So those neural connections are more plentiful and are more strongly created. And so that is the behest of what we do at OmniLife Virtual Reality and how we use virtual reality in the medical space. Once again, like I said, we really work in that mental health space. We come into clinics with equipment and software that they can take right off the shelf and begin to have performance improvements with their clients. The same thing with Corpus VR in the physical health space. We provide equipment and that software access, and of course the training and service to come right into a clinic or a hospital, provide them with all that they need, to include the information how you bill to Medicare and Medicaid to have that covered. Virtual reality as a behavioral health, physical therapy, or a speech therapy is a standard modality recognized by Medicare and Medicaid. You just have to, they ask that right now when you do your billing that you add the 007A code to the back so they can begin to capture how many people are using virtual reality. So and then that third space, of course, that we come into the aging communities and we provide that holistic wellness through virtual reality, which often looks like entertainment from the outside. But once you're inside that virtual reality environment, we're doing all the things to make you aware of time, make you spatially recognize where you are. The problems and puzzles that you have to solve aren't just right in front of you or rudimentary or even linear. And that's a lot of what we have to do to really make sure that the mind has all the exercise that it needs to have, especially as we age. So I could probably talk for days, but if anybody has questions, I would sure love to hear what they are.
Thank you, Johnny. That was great. I have a question regarding the sort of memory imprint that you're trying to accomplish with many of these applications. How sustainable is that?
So the evidence on that for us in America is pretty new. There's a whole lot of case studies that we can look at, but there hasn't been as much comprehensive as we would like. Now, what we'd have to do is we could look to Europe and what they've done. Now, they have quite a few case studies where in the Alzheimer's and dementia space that they're able to make what they call significant endurance. So now what we say is that we of course we cannot reverse dementia or Alzheimer's. What we do is we stave it off by keeping those neural connections strong. And now what we do know is to keep those neural connections strong is, of course, that exercise. Now, as our company, we don't have a history of what I could tell you that date is. All I can unfortunately give you is the white papers and anecdotes from the American side right now. Now, we are pushing to change all of that because there is much more research that needs to be done on that particular aspect of how virtual reality affects the memory.
Other questions from the team?
Yeah, can I tag in on the end of that question you just asked? And so would the goal be that an individual who has Alzheimer's would buy one of these VR headsets and use it as part of like therapeutically, just like you might take Aircept or something like that?
Oh, absolutely. That's exactly what you do. So so it gives you those exercises. So now with physical therapy or any sort of mental exercises, the thing that we have is that people don't perform even if you teach or show them. When they go home, they don't do it. Well, when you put them in a virtual reality headset, the thing about a virtual reality headset is you are compelled and compulsed to interact with your minimal environment. You know, we're so attuned to all the information that comes into us and to reacting to it. As soon as we put you into a headset and we get rid of, 70% of the rest of the world, and you are limited to what it is that you have to interact with, you can't help but want to interact with the story that I give you. If I give you two options, you will choose one or the other. If you can look around, you will. If there's something that you can interact with, you will. So I get questioned oftentimes about virtual reality and the elderly. Do they use it, or do they want to use it? The first thing I do is give me an old person and let me just put it on their head and we'll see what happens. And before you even give them directions, the way virtual reality works for us, because we have created a simulacrum of the world around us, you are absolutely bought in already. It's very intuitive. And so, yes, so the answer, I'm sorry, I'll get back to the question. Yeah, so we provide equipment and experiences. I can give you just like a headset, depending on what we put onto it, but it's usually like for a clinic to run, say Corpus VR, the physical therapy suite. I mean, you're taking like $400 or 400 bucks a month for like a setup per setup. So the recovery on that is really quick, your ROI. Things that we send home, of course, most of that software, they dumb it down so they can bring the price down. And we provide the best equipment, but only all the more that you need. And we can start to get units into somebody's hand for, about between 15 to 2,000 is it for take home total package. So if you kind of spread that out, a couple $100 a month or something like that. So that's kind of where we are in the physical space. The psychological space, it's a little bit different. A lot of that goes into the clinician space, and then they'll send that equipment back out again through their clinic. And so that they're probably talking right about the same thing, looking about 1,200 to 1,500 for a headset to go home with a client. For in the clinic, it's probably a little closer to about 5 to 6 for a headset. There's a lot more controls that they have about how they interact with those clients. So there's a little bit more to that. When we talk about the holistic, when we come into the aging space, we're going to treat dementia or Alzheimer's. There's a couple of ways that we do that at large community centers. We'll bring in a full commercial grade entertainment rig with the TVs. It looks like an arcade almost, really, really nice looking arcade. But then with booking software and the whole 9 yards, and all the residents will be able to call in and pick a time that they want to come down and do an experience. And we will put on those rigs the experiences that we know hit those indicators that we need for those that have dementia or Alzheimer's to make sure that they're being cognitively exercised like they need to be. So there's two terms of that. It could be an installation in a space, the biggest equipment, or we have those portable units that, although they are the best equipment for where the industry is.
Brian?
Yeah, you talked a lot about collecting data of patients. What are your processes, and especially being in the European market? So what are your processes for GDPR's data deletion requests? And furthermore, are you employing decentralized identities? Because it's really easy to identify a patient through head movements patterns. So I'm wondering how you guys plan on interacting with physical movements that they can tell who is using the device. How you manage that cybersecurity, the data deletion, and if you use decentralized identity.
So there's a couple of good questions there. So it depends on what we're doing. So like in the physical therapy space, most of that, we operate within wherever the HIPAA regulation is, and for that data security, you'll get client side security. So whatever security that you're using in the clinic would be what you would be protecting that data with. Now that data transfer comes in a couple of ways, and as long as your network is encrypted appropriately, data transfer from headset to a home unit would be covered and secured as well. Now, when we talk about maybe in the psychological space, what we do with SciTech, some of that, like indemnification or abusification of what that information is, I don't want to speak out of turn. That's not the side that I deal with as much. That's a little more tech side than I deal with on that side. What we do when we've imported this into America, it fits and follows the regulations for data transfer. In fact, some of what we use when we do our billing is actually through telepresence. That's the Medicare and Medicaid billing format that's come out since COVID to be able to do that data transfer. So I can't answer your question maybe as deeply as you would like me to. All I can tell you is that we fall within whatever current regulation there is to keep that data safe.
Thank you. I mean, I just think it's really important because people trust these companies to keep their data, and then 23andMe, all of a sudden blows up.
Oh,
so
right.
All these people have lost all their genetic data, and they don't realize how much money it's worth until they hear stories about it all of a sudden on sale on the web the next day, So they
Right.
paid a bunch of money for the product, and the company's making money off of their information. So I think that's a very important ethical consideration.
No, no, you're right on there. So actually, I didn't want to get deep into it, but no, there's some that's exactly, we do concern and consider that as part of what our approach is and keeping that information safe. Now, most of that is, like I said, that information will be stored locally with the clinic. That's not something that we capture as a company or SciTech as a company captures. Now, that biometric data, some of that may have to go to cloud processing or whatever. That information will be two-party secured in whatever methodology that is being used. I'm not sure what that regulation is, but so that data transfer, all I can say is being secured. Now, what we as a company do with that information, all that is obfuscated, it's indemnified, so we don't know who is on the other side. And now there's some of that process, and I don't want to speak out of turn, is I know that there's some disassociation with how that data is stored, so that if we keep data, it is pulled away from the client so that you're looking at it more sterilely. You're not seeing the whole picture.
Okay. Great. Other questions? Elizabeth, did you have something?
Yeah, just one more comment than a question, but thank you very much, because I just think virtual reality is one of the things that has made a huge difference. And my experience, just as now, is also in Europe. I've done a lot of, I've experienced and seen it, not that I've done virtual reality myself, but I became aware of it when I worked for a company that does cognitive therapy, everything about cognition, the effects on mental health. And it's all of that work actually outside of England was done in the Netherlands. Netherlands seems to be a hotbed around the world for some very, very unique discoveries and testing. But one of the things that they are starting to do over there, and I'm not sure if you're involved with it or not, John, is actually using virtual reality regarding chemobrain. Because a number of years ago, back in 2015 and 16, at the University of Utrecht, there was clinical trials done on, cognition and chemobrain. And the extension of that now is the use of virtual reality and managing chemobrain, if you will. Do you have any information on that? And by just another side is, Europe and the UK are so strict about GDPR and what happens with data and so on and so forth, that I am assuming that that everybody is following that in terms of clinical trials and so on and so forth, because they are so tight and so regulated. So you almost need a degree in GDPR. But anyway, let's take your thoughts on whether you're seeing or going to be working on chemobrain.
So but in particular, chemobrain is not something that we've looked into. That sounds very interesting to me. I might reach out to some of my folks out there in the Netherlands, and there's a couple. I get asked this question quite a bit. Like, why is the Netherlands the hotbed, in fact, and why is it that I'm just now hearing about some of this stuff? So a little bit of the history of virtual reality that I didn't quite get into is the modern history of virtual reality. So everybody remember a guy named Lucky Palmer? Anybody remember hearing that guy's name? So Lucky Palmer is the cat that jumped out of nowhere, who suddenly decided he wanted to try to make virtual reality a reality in the modern era. And he was able to do that because, there was some political stuff years before that they decided that they were going to release some of they weren't the government and the military weren't going to re-up some of the patents they had, many of which were over the virtual reality that kept it out of the civilian sector. Well, all of a sudden, the patents on these things opened up, so Lucky Palmer was able to start to do some of this research. Well, he got far enough with the cardboard and a cell phone that the big guys got in. You know, we're talking Zuckerberg, we're talking Amazon, we're talking everybody, and they dumped billions of dollars into the industry in an instant. And so what they did is they took the handful of guys who knew how to do all these things, pulled them out of the industry, and instead of these guys being in, you know, year and a half development cycles and then coming back out and telling everybody what they were doing and how they were doing it, teaching more folks to do it, they all got locked up in these non-competes and non-disclosures and everything, and weren't able to develop the industry as educators or even performers within the industry. So for 10 years, we've really had to rebuild the development side of the industry. And that's everything from outside tech, which is like our guys over in the Netherlands developing the undercarriage for the headset to read the biometrics. That's people being able to create the correct software at a commercial development grade and level so that it's something somebody wanted to have. For so long, the only thing, we had great technology, but we didn't have good experiences. There wasn't anything worthwhile to do. And so we're really right now at the Pilion where all three of the, or those things have all come together, where the technology is sufficiently qualified, is of sufficient quality to give a good experience, and has come down in price that we can afford it to distribute it commercially, and that those experiences have grown to be developmentally of commercial grade and of value. Now in the Netherlands, they have really spent a lot of energies and money within the government to really push technological advancement within AI and virtual reality. So they had a lot of money, they had opportunity and inroads within their hospitals and clinics to begin some of this process. So they had a big leg up on us. And as OmniLife, we develop and we pull off the shelf whatever is necessary for the client. As we were going through early in our career within the industry, we were looking to develop physical therapy and mental wellness for ourselves. But when we looked over to what was happening in Europe, they were leagues ahead of us, and why fight that horse when they were already solving some of those problems? We just started to import that and help them develop that along the way. So virtual reality can really make great inroads, especially where you're talking about with the chemo brain. I can only make some assumptions that it's kind of following along with that, keeping that mental faculty stable is what we would call that. So that the plasticity of the brain has high retention, but you don't, but if you keep it too high, then you begin to lose the memory itself. So did I answer your question?
Yeah, it does. It's just all, you know, the chemo brain clinical trials over the last number of years have been really about maintaining cognitive function, which of course maintains your mental health throughout, you know, what is otherwise a devastating, you know, therapy. But I know that the Netherlands and the University of Maastricht and the Utrecht University they're very well funded, but they're also very much into innovation transfer to help what they get, bring it to the United States as and when you know, somebody can help bring it over, such as yourselves. Mm-hmm. Anyway, very interesting. Thank you very much.
Yeah, the mental health space is probably because that's really what we're doing, no matter what we're doing in virtual reality. It's that the virtual reality headset, you can think of it as the technological interface between the brain and the body. We can use the brain to affect the body, and we can use the body to affect the brain, and so it's a back and forth. And one of the things that we know, you know, I love what I do because I get to touch up against psychology and technology and all of it all together. And how we begin to understand, you know, the brain and how it makes decisions and the chemical induction. And I started off kind of talking about how virtual reality is really the ultimate storytelling device. I mean, and that's really what we use it for. When we separate the psychological from the physiological, which is what we can do in the headset, when we put this headset on you and we block out the rest of the world and we feed you just this information, we're able to separate those two stories. And when I can make your psychological story more compelling than your physiological story, that's how I can override your pain tolerances. I can begin to make you disassociate from things that you don't want to be, that we don't want you associated to, and make associations to things that you would not naturally want to have associations with. Now, especially one of the great things that we're able to do with virtual reality and telling that psychological story is that it brings down the filters. When you're in virtual reality, you're immersed in the information. So instead of information coming to you, it feels like that information is innate within you. So it brings down all these psychological filters about what information I'll even allow into myself. And through virtual reality, part of the storytelling that we do is induce a state of mind, that mental state. Now we know your emotions drive your chemicals and your chemicals drive your emotion. So when we put you in, we tell the right psychological story and induce the right chemical state, we open you up to a sense of wonderment. And you are open because your filters are down psychologically. You have the right chemical makeup for the state of wonderment and to create those neural connections. And then when we feed that information to you, you trust it, you take it in, you don't question it. And so that is really the behest of what about virtual reality and how it works, is that we're able to separate those stories and make the one that we tell you more compelling than the one you knew before.
That's great, John. Thank you very much, Johnny, for that presentation. It really hit home, and I think that it's something that we can think through in terms of following up possibly with you about some use cases at some point in the future.
Absolutely. Yeah, I would love if anybody would reach out to us. I dropped my information in the chat link. Please reach out to me. And if anybody would like to, they could share theirs there and I'll grab it as well. And yeah, we're looking for folks that would be willing and wanting to bring in our equipment and do some use cases with us, because, you know, we have to just reproduce what they've done in Europe. And we'd like to see that happen with, you know, those right here in Kansas City.
Juan, did you have one more question? Juan, are you still with us here?
Yeah.
Okay. We've had a few folks join us since we started. Let's just do a quick introductions before we kick off to the presentation that Elizabeth will join us with. Ryan, do you want to say hello?
Sure. Forgive the dark past here. I'm kind of in a radiology office, but that was really great, John. I wanted to say that, but I'm also the ambassador for Blockchain in Healthcare Today. It's a peer-reviewed magazine for blockchain in healthcare. It's an international magazine reviewed by all physicians and clinicians, and really trying to advance that. I also am the developer of Envelope company for decentralized patient files. So, and we follow a lot of the GDPR stuff. So just to talk to John there a little bit, yeah, that's something we focus on. And I know a lot of VR markets that do something similar to this. So maybe we could reach out someday.
Sounds great. Thank you, Ryan. Steve Stool.
Thank you. Sorry I was late, had a call. Steve Sewell with Sino Chips Diagnostics. Little bit of a stretch on the digital, but we do pharmacogenomics, one of the only labs in the United States that has approval from Medicare. So it's a pretty cool little lab in Kansas City that no one's ever heard of.
Thanks, Steve. Craig.
Morning, everybody. Sorry I was a couple minutes late. Craig Mason, co-founder and CEO at Raise. We develop AI that integrates into communication tools that does early mental health detection.
Thanks, Craig. Steve Kropp.
Thanks, John. Steve Kropp, Director of Telehealth at the University of Kansas Health System. We've got a program some of you may have experienced. We had outpatient, inpatient. We're also engaging in a remote patient monitoring program for sensitive chronic patients that can benefit from a telehealth program.
That's great. Thank you, Steve. Ross. Ross, you with us? I guess not. Aaron.
Hi, Aaron Deacon, Managing Director of KC Digital Drive.
Great. Anybody that I missed? Okay, with that, let's turn it over to Elizabeth Crocker. Elizabeth has a great deal to say to us about the integrated care model and its relationship to technology, and I'll let her take it from there.
All right. Thank you, John. Let me see if I can share my screen. I get technology challenged when I have to do this.
There we
Can
go.
everybody see that?
Yes, if you want to expand
Ah.
it, we'll be in good shape.
Can you see that as a slideshow now?
Absolutely.
Okay, thank you. Boy, that dry run the other day, John, helped. Thank you, John, for the introduction and for this opportunity. I really do appreciate it. And hello to all. Since I've moved to Kansas and have become involved in it, I have recognized that the metropolitan, urban, and the rural areas of Kansas and the Missouri represent a unique opportunity for the digitally driven and supported integrated care systems. Since 2004, I have worked with digital health and integrated care, albeit a lot of it over in Europe and the United Kingdom and elsewhere. And I would like to share what I've learned and continue to learn, along with my unbridled dedication to improving health for a better quality of life. Let me just get rid of that. Some of what we talk about today, we have heard before, but it's the reminders and the reflections that must drive what and how we innovate, for what purpose, and for what expected outcomes. Oops. What is digital health and how does it enable integrated care? The importance here is that digital health is, enables technologies and support functional activities and processes. We have to look at, what are the values we're trying to address? What is the culture that we're trying to address? Have we met an unmet need? Will it make things better? Will it be culturally compatible? And this is something that we don't actually address as often as we should, is the cultural compatibility of what we're trying to do. And this is everything from, the cultures of people, the cultures of providers, cultures of countries. We just heard about what, is happening over in the Netherlands, where they have a very adaptive culture, to say the least. And, using those lessons as in when, you want to transfer something like that over to the United States. So this is about purposeful and, thoughtful innovation. The foundational ideas behind all of this is really, really important. Again, I always ask the questions again about the interpretations of attention to values, our beliefs, and our norms. Are they interwoven into a model of care at the individual, organization, and society levels? So a couple of people that are in this call today that we know are doing some wonderful things and addressing various needs that are definitely interwoven into care, such as Chuck Schneider's read it, and he's working on EHR. And one could say, well, what has EHR got to do with integrated care? Well, it's part and parcel, because the information and the fact that, the data that they're gathering and how they're using EHRs will have a direct impact across many, many aspects of care for providers as well as for the people who are receiving care. Randy Archie's Ask Sammy, another example of an unmet need that is addressing the cultural and social aspects of integrated care, and is very much important part of integrated care systems. Craig's Rays, that's another one, mental health. So when we're talking about integrated care and society levels and so on, we're talking about, adult, children, there's nobody to be left out. So what is it? Now, we've seen these definitions, by and large in many different forms, and we have been talking for years, literally years, about breaking down the silos. But I have to say, in my, not so humble opinion, that we're not doing a very good job of it. We have a long way to go. We have to be more collaborative, more communicative. So when a couple of people I was just talking about, for an example, how do we include all of them? How do we include Rays? How do we include, Ask Sammy? How do we include virtual reality, as an example, into an ecosystem of collaboration and coordination? So they are part and parcel of the journey. The integrated continuum and continuity of care, these are not synonymous. We often think that they are, but they're not. So the continuum of care affects all of us. It is basically cradle to grave, from the time we're born to trying to prevent, unwellness, to staying well, to being ill, to getting to self-management. And sadly, all of us have to have some type of end of life care. But the important part of this discussion today really focuses on continuity of care and the coordinations to be effectively managed. Primary care, acute care, tertiary care. Tertiary care, a term that we don't use as often as we should, is really how do we get in and out or migrate through a system, if you will, taking care of long-term condition. How do we use remote patient monitoring? The new focus on care at home, out of hospital care, virtual wards. These are all very, very specialized, if you will, aspects of integrated care and the digital and the importance of digital health in driving these, supporting these, and delivering these types of things. Why is it important? Well, we talk a lot about holistic and person-centered care, and these are, in my view, two of the most important goals of any kind of care system, because if we're not treating the whole person and we're not putting them at the center of their own care and plan, then we're missing the boat. And this is one of the reasons why so many people are frustrated, they get confused, and they don't actually know where they are in the system, so to speak. And it has nothing to do with their intelligence or their socioeconomic status in life. It just has to do with a function, with a system that functions in silos and sadly sometimes is dysfunctional. So again, I want to express, the continuity of care across primary and secondary, the collaboration and the coordination that's required to make this successful. Digital health is key. This slide in its simplicity is probably one of my favorite slides to use, because everything about digital health and everything about integrated care is about improving access to metropolitan care, urban care, rural care services. And we, when we think about the three areas of where people live, they either live in a city or they live in the suburbs or they live out in the country. All of them are, entitled to and should have access. And this then enhances what we talk about equality of health. If we improve the access, I believe, and I have seen that what follows is that there is much better equality in the care that is available and delivered. And then following on to that, we expect and do see the enhanced quality. And then following on to that, we also see improved outcome. This has been, all of these things have been documented in various papers and studies. Some of it's been done obviously overseas, but there has been a lot of it done here in the United States. Digital health, it's like the grease and the glue. We need both, and it provides both. We have to transform the current systems into something that's more integrative, into interoperability. We'll talk about that a little bit more, but we see interoperability and data data sharing. We talk about these all the time. We're not necessarily doing a great job of it all of the time, but there's been a lot of improvements in, interoperability and how are we gluing infrastructure together. What we have seen is interoperability, probably philosophically, is more achievable and it's happening more often. Data visualization and data sharing, I think we're still struggling with these things, and yet without data visualization and data sharing, we don't have the information that we absolutely need to continue to improve quality and so on at all the parts of the integrated care system. COVID has had a lot of positive unintended consequences in spite of itself. We have on one hand seen that we can, in the bioscience and biotech field, actually, develop, diagnostics and therapeutics a lot more rapidly. It has become a force of nature in terms of providers being able to use more tools, being able to carry on with their assessments of care and delivery of care. If you look down at number 3, though, again, I focus on data sets are being more integrated, but however, the infrastructures to barriers and interoperability do remain a significant barrier. And these are, I believe, need to continue. We cannot lose sight of these at any time. The other thing that we've seen, obviously, is a change in policy and a change in funding. CMS and was forced to reconsider how, and a lot of payers have been forced by nature to reconsider, payment reimbursement for telehealth, virtual wards, and things like that. So those things I know we need to continue to support. We need to do a lot of work in the policy area to make sure that funding not only continues as it is, but it gets better. It has to get better. It has to get more widely adopted. But we've had a lot of threats to equity and the role of digital tools. One of the things we need to avoid is the fact that we don't just look at it as another tool in the toolbox. It is a lot more than that. But we do have to create, as I've talked about before and earlier, it's about coordination. It's about collaboration. It is about sharing. And we are still, I could talk, for days and days and days on a soapbox about data and sharing. And that was brought up earlier in the conversation about VR and, data capture and so on and so forth with refer to GDPR. But here I've attended so many meetings where they talk about the difficulty in getting providers to share the needed data. So finally, these challenges, they can exacerbate in health inequity, and we have to pay a lot of attention to this again. This is not about we build, they will come. This is about we build, we bring, we teach, we educate and support so that we can overcome the unequal access to technologies and the disparate digital literacy that is out there in reality. So this is what this is from the Digital Medicine Society, of which I'm a member of. This is the big picture of what digital health is. It's a wraparound. It's a transporter. It delivers, it captures, and it delivers clinical evidence and real-world outcomes. So these 3 aspects of it is really 2 aspects: digital medicine, digital therapeutic, are gathered together and transported and shared through digital health, which is really a communicator and a transporter. The definitions of, digital health and so on is, again, digital health is the wraparound, is the delivery, it captures, it stores, it transmits. Digital medicine is all about evidence-based, software, the clinical evidence, and so on and so forth. And digital therapeutics, which are many that we know about, certainly even with COVID vaccines, that's a digital therapeutic that was put together. But mostly, it's really about, a lot of this is in med tech, that we see things that are happening the way they're gone. This is the world where I have spent, the last, 19 years, I suppose, with working with all of the types of companies that make up digital health, digital medicine, and digital therapeutics. This is an area of highly regulated, when you get into digital medicine and therapeutics, especially, highly regulated, between the FDA and the CE in Europe and so on, the regulatory environment in China and Australia. All of these things, in order to be used around the world, have to, from area to area, go through a massive amount of regulatory, gymnastics is what I'll call them. Not necessarily as fun as gymnastics are. However, these are the things. So when we were just, we've looked at things today. We've heard of a number of the people who are in our audience today do other presentations about the various things that they are doing digitally in terms of software, whether it's for mental health or virtual reality, or different things. Even though somebody who's not on our soul today, but she's been part of this program. Everything that helps gather information and help people. Now, this is the big picture. Every one of these applications is part and parcel of a fully, totally digitally driven integrated care program. People, by and large, who, if you look at all these different aspects of things, somewhere along the line, one or more of these will be required for a particular person who is in a health system, who is being treated and or will need to be treated. There's no getting away from these at some point. Telemedicine is the one that, of course, is getting a lot of airtime now, virtual rewards, so on and so forth. But even looking at things like surgical on the left, the robotics, the remote sites, the targeting devices. So this is, a full picture worldview of what I call the digital health applications. And this is the digital health infrastructure. Again, we were just talking earlier, the things like, access, engagement, equity, and ethics, privacy, and identifier protocol. And I think, the question was raised earlier, and this is, I think, one of the biggest stumbling blocks into the sharing of data. So it's so important, but it is not an impossible obstacle to overcome. We just have to keep doing it and doing it and doing it. We see interoperability. We talk about virtual health data, trust and governance. This is what makes up digital health infrastructure. And the National Academy of Medicine issues these core principles for the stewards of digital health. It needs to be personal. That's where you go back to whole, person-centered. It is holistic. It needs to be safe. It has to be effective. It has to be equitable and available to everyone. Efficient. One of the biggest outcomes is that we are seeing more efficiencies in the use of digital health across an integrated care system, because the integrated care is intended to be efficient. It's intended to be more accessible. It's intended to be measurable and so on, because digital health provides the tools to deliver on these principles. Creating a successful digital health integrated system starts with a demonstration project. Now, this particular model, which comes out of the National Institute of Medicine, is the one that I have worked with in all of the digital health demonstration projects and integrated care demonstration projects that I've been involved with. This is adaptable. Not every demonstration project turns out to be the same. So while this model is very adaptable, it's very fluid and flexible, it's also used, so you start with a demonstration project, you follow all of these principles. Obviously, you have to be flexible in them. But again, from one demonstration project to the other, what we do is we take out all of the outcomes and we'll go to another demonstration project will be in another area, maybe address another area of health, because we focus on geographic areas, we focus on population health, such as diabetes, population of diabetics, or population of coronary artery disease patients, a population of certain types of pediatric childcare, and so on and so forth. So the models are replicable, but they are not, we don't necessarily duplicate them. And that sounds probably like I'm talking out of both sides, but replicating something is because you've adapted a model to a particular area, culture, available resources, and so on and so forth. So what's next? Setting the stage for improved integrated delivery model. Overcoming the path dependency theory. The path dependency theory basically is, are we relying on our past experiences to guide and dictate what we want to do today or tomorrow? Or are we willing to take a leap of faith, what I call jumping off the cliff without a bungee cord, and doing things like asking questions today about tomorrow's technologies, aligning functional activities with the core values, and ensuring that digital health will play a greater role in the integration of health and social care, and by and large, capitalize on all of our windows of opportunity. That's a short and synopsis of, the world of digital health and integrated care. And I look forward to working with all of you and the future of this in America's heartland. Thank you for the opportunity. Have a good day.
Thank you. Thank you, Elizabeth. That was really great. I particularly liked your section about how technology is actually adopted, and that is that it really has to be kind of a comprehensive, holistic effort to go out to where people actually are, rather than just assuming if you build it, they will come. So I think that was a very important feature of your comments.
Yeah, I think that, a lot of technology historically, and there's evidence of it and some sad stories about it, is we come up with a great idea and we just think it's the world of the bee's knees and everybody wants it and so on and so forth, and all we have to do is put it on a pedestal. And that's not reality, and it certainly flies in the face of everything that we want to do in terms of the quality of care, and overcoming or more or less, we need to create all of those bridges, and we have to bring it to the people. That is the only way it's going to work. And it's not a one-off. It's like you go out there, you bring it, you constantly educate, you constantly support. It's something you just have to do almost 24/7 to make it work.
Great insight. Thank you. Ryan, did you have a question?
Yeah, I think you brought up some great points, Elizabeth, that we talk about a lot at the IEEE meetings and healthcare and blockchain all the time. I can't help but think also that a lot of the integration processes that you spoke about are legacy models trying to uplift it by doing some kind of upcycling, so that there is no replication, meaning that, higher sources appropriate the information to make it more readily available because private companies are unable to work with each other. But in blockchain, we kind of build for 100-year models because, like I said, 23andMe and all these other companies, they're like data privacy and all this other stuff. And I mean, Facebook, all these places, every single time they go away. So when I hear people talk about an equitable structure, especially hospitals, I'm really kind of confused about what they consider to be an equity structure, because in blockchain, we reduce the cost of Medicare medical costs by providing them the income that hospitals make off of their information. We let them make money off of that information instead of the hospital. I view that as equitable. And when you have the data producers and the data creators and the data consumers, like you do in the GDPR market. So I just want to know a little bit more about the equity structure that people see, because people aren't engaging in their health because they have no incentive to. They don't own anything. They don't get their records. They pay a lot of money for it. So when people own a house, they have interest in it. You don't own your medical records. So how do you get patient engagement without patient ownership?
Well, to me, that is one of the biggest problems that we have seen for years and years. Going back to the days when we've talked about, patient choice as an example. How do you even deploy patient choice? How do you how do you get people involved? I believe it's a problem that requires a lot of thought on a day-to-day basis. In terms of owning records, what I see is two sides of things. People are really keen to own their records, have access to their records, and certainly the availability of Epic and MyChart and people that have put together so much work into saying, here is my personal health record. I have access to it. I can use it. But the reality of it is that there's also a large part of people that don't want that. So we have to find the balance. Equity to me, and just to go back to the idea about data as an asset, I mean, using data as an asset in the world of health is not as popular as using data as an asset in the world of retail or finance or anything else. Again, we run into the privacy, what are people going to do with my data? Are they going to find out that I've had a mental health problem, etc.? But when I talk about equity across the board, and I think about equality across the board, I'm talking about everybody, regardless of your socioeconomic background, regardless of where you live, will have equal access to quality care, and the ability and integrated care systems and the use of digital tools to provide that. It has made massive strides and improvements in this here in the United States and so on. I mean, a couple of systems that we're aware of, the VA is an integrated care system. Kaiser Permanente is an integrated care system. Two others that we don't know much about, or we don't hear much about is what I should say. Partners Healthcare up in Boston is an integrated care system. Another one is the Rhode Island Medical System. They're an integrated care. Everything is literally attached to everything else.
Intermountain too. Intermountain, you should check out them. Intermountain.
Yeah, I mean, I'm aware. I said there are a lot of them, but those are, for we all know about, in another life, the VA was actually one of my clients, and so was Kaiser Permanente and Partners. I've worked with them extensively. I don't currently because I'm not in that part of the business anymore. But your point is well taken. But from a patient or a person's point of view, having an electronic medical record has made a difference in their life. Being able to have virtual care, being able to have a health consultation online has made a big difference in many, many people's lives. In parents who want to have an immediate consultation about their child and not have to go to an emergency room or so on and so forth. Telehealth and virtual care, virtual wards to be able to bring people home. I know that John is working on some things regarding health at home. I've had some great experience with that over in the UK. It's a phenomenal model. So it all has to work together. But thank you for asking the question. It's a really important question.
Doug.
Yeah, a great presentation, Elizabeth. So a couple comments and then a question. One is, even though I think it's 30% of the data generated by the internet last year was medical data, 95% of that data is never looked at. And so we generate lots of data and not doing anything with it. Another statistic is like there's according to the CDC in the United States, 1 billion doctor's visits a year happen, in a small percentage. During COVID was higher, but now it's less telemedicine. So I guess the question, and then the third thing, as I'm looking at artificial intelligence and how artificial intelligence can help the clinician, help the patient be more efficient. And I think telemedicine is an area of this as well. And I appreciate your slides on looking at adding AI to that. So I guess the question I would say is, do you see a reduction by doing this? Are you trying to get the increase in telemedicine visits so people don't have to go into the doctor's office if they don't need to? Or is it to have more access, to reduce, the cost of the visits? I mean, what is kind of your focus of your program?
Well, integrated care is designed to increase access, decrease hospitalizations, and focus on self-management and so on. So when you put together a holistic program, you really are looking at all the aspects of, what does that person need to have a good care outcome, to have a good care pathway? Where does telemedicine fit in? So if I'm well and then I go into the hospital and then I have to come out of the hospital, that continuity to create the environment for ongoing good care, self-management, and better outcomes. So to go back to your point, though, Doug, that you raised about data and we don't look at it, when you're building an integrated care system, that is let's just put it as a module. We're going to choose an area of a geographic area, and we're going to choose some populations, whether it's population, when population health is like diabetes, coronary artery disease, so on and so forth. And you build an integrated care model around that. So therefore, the data that it was in that, usually there's always somebody that is promoting and making sure that we are looking at the data that we are collecting, the evidence-based data, the patient or, reported data, the family reported data. You put that together in an outcomes measurement model, and that's how you reuse the data. It's not about looking at the entire country at once, where you're absolutely right, the data just sort of sits and, vegetates. We're looking at creating the systems. So every integrated care system is geographic in design. It is around population health and so on. And so all of the bits of areas, we talk about holistic, we talk about comprehensive, we talk about the continuity. What does that patient need at any given time in their journey? Is it a virtual ward? There's been a lot of work done in Europe and the UK about virtual wards around cancer, children or people waiting to go into hospitals, that all of the things that need to be done for them preoperatively, they're being done through virtual wards. They're being done through care at home. So it is not like when that, that big worldview that I put up, all of those are available at any given time, or should be available at any given time, at any given point in a patient care journey, whether it's wellness, whether it's illness, whether it's, self-management and recovery. I hope that, answers your question. It's good to see you again,
thank you.
by the way.
Good seeing you.
Johnny.
Yeah, thanks, Elizabeth, for the presentation and for the stirring conversation on data. I never quite know what to expect in these conversations when I show up to them. So I'm always glad when they're curating like this. And I want to thank the questioners so far that have really kind of instigated where we've gone with this. And Doug, I want to kind of piggyback off what Doug said and ask a question, and then I want to ask one of my own. So this data capture that we're talking about, I'll just kind of throw a log on the fire here as an engineering minded designer kind of a guy. The thing that I do know is that we have to capture the data, and the AI guys in here and the other folks that are looking through some of this data will back me up on this. We have to have that data set to work with, and even though we're not doing anything with it right now, we have to capture that information now so that it is a large enough and comprehensive enough set of information for us to really get something out of. One of the biggest failings of data capture is we're not capturing the right data. So if you're not capturing the right data, you have to capture a whole lot of superfluous data and try to make something of that information. So there's a couple of things that we really need to do about that is continue to capture that data so we can build those data sets to work from and make sure that we're really asking the right questions about what data we are capturing so that we can do something with the right data rather than trying to make all these inferences that are hard for us to come by and then difficult for us to implement or recognize to be true. So I just want to throw that log on the fire, and maybe I'll let you give a chance to rebuttal on that when you get to it, Elizabeth. But the question I wanted to ask is, because there's a couple of us in the room today, is how do you feel and what do you see for that private marketplace? How does this fit within what your big plan is here? Now, Craig from Raise is working, with marketplaces and AI to try to figure out and connect patient need with the care. That seems to be a lot of the journey many of us that work in the data space are trying to solve. And there's a couple others, within the SciTech that we sell, that software system. There's a digital marketplace for somebody who needs care to go and find it. And one of the reasons that we really jumped into there is because there aren't enough caregivers to give the care that we know needs to be given. The AI that Craig is using is to try to jump in and find those that are at the highest risk so that they can find care the soonest. And so then the other side of that coin is how can we saturate the market with reasonable and recognizable care that does have impact and does create performance and betterment for folks, but doesn't have to tie up the rare and few clinicians that those in the most need can have access to. Now, there's a couple others that are working to try to make sure that everything from patients that like Dr. Shelley Cooper, her program is to try to make a marketplace that folks can find an open appointment if somebody cancels. So there's an there's an interconnection of those clinics and open spaces so that you can find a place to go if suddenly an opening happens. So how do you see that private marketplace fitting in with what you're trying to propose?
Okay, good question. But I also want to comment on what your first thing about the data and not always capturing. I've worked with developing outcomes measurement programs for years. I studied this at Harvard, and one of the things is we talk about is what is it that we actually what is it we're trying to achieve in terms of outcomes measurement? And then you reverse engineer that. So we have a tendency, we being the ubiquitous generic we, nothing personal here, is we just come up with an idea. I want to capture X, Y, and Z data and, and then figure out later what I'm actually going to do with it. And that's a little bit cynical, but that's unfortunately what we see. If you start with the premise, what is it that I actually need to know to improve outcomes, to provide continuous quality improvement, of whatever it is you're trying to do, and you reverse engineer it and say, okay, if I want to measure all this, then I need to capture this. And that's one of the reasons why a lot of data that we do capture does not translate, if you will, into actually useful, actionable information. And that is a model that, by and large doesn't work. We've got to focus on the design of what it is we're trying to achieve. And that is really important. To go to your other thing in terms of, again, I go back to one of the things, I also am an advisory board member with Doug on the KU School of Nursing. And one of the things that we're working on, obviously, is problems in the workforce. We all know that nurses are leaving, caregivers are leaving. It's unfortunately, and I'm a nurse, so I just can't imagine what's happening to my profession. I do know what's happening, but it's very sad. So to go back to the availability in the private sector or in the private market, quite frankly, the private market has, even in Europe, there is a big private market in Europe. We always think about things like, state-sponsored healthcare and blah, blah, blah. But there's a big private market, both in technology, obviously, and care provision. And certainly over here, our private market is massive. And I find that the private market has been great supporters of, providing for and creating opportunities in technology, access to care, follow-up care, and so on. I think the problem that we're facing is this reduction in workforce. I think our society is tired right now. I think we got worn out by COVID. I think we get worn out by, I don't know. We're trying to discover all the reasons for nursing shortages. It's burnout. One of the things that Chuck is working on with, is trying to avoid burnout. There's all sorts of ways to avoid it. So the problem we're having, that we don't have the workforce that we need. One of the things I know that we're doing over at KU School of Nursing is not just looking at the nursing, but by and large, how do we attract the people that are necessary to be available to all of us in this integrated care system at any point in time that we need them? And that's where we're at. I don't know if that answered your question, but it puts me on my soapbox.
Thanks,
I think
Elizabeth.
I
That's
have an
got it.
answer to that question. Oh,
Go ahead, Ron.
go ahead, John.
Go ahead.
Oh, about achieving the right people. A lot of healthcare organizations will have a demerit chain for their employees, and they don't give them a merit chain for them to take with them, like best employee of the year, or these types of things. There's no proof that that happened. And sometimes the corporate world, a promotion is seen as your merit chain. When that can't always happen, and you see a lot of these people get into these equity groups to help the hospital with equity and stuff in the community, and then their names aren't attributed to the report in any kind of equitable manner. So I think employees feel like they're not getting the attribution and the input that they feel. So if any corporate organization were to add a merit chain instead of just solely having a demerit chain, you may be able to attract more talent because they'll be able to take those digital certificates with them.
I agree with that 100%, but a lot of different corporate models are meritorious, and they run on a meritocracy. We're not always aware of it externally, but we're seeing more of that. I think what we see in healthcare is it's overwhelming at the moment. COVID did a lot of damage to our workforce. There was no question about it. And I think, one of the things we're working on at KU is looking at the various things that we can do to attract people into, say, the nursing profession. Let's just focus on that at the moment. Track them into the nursing profession, keep them in the nursing profession, and not just at the hospital level. I mean, I've been a nurse, never mind how long, since 1974. And my career has been very diverse. And I want to see people like myself enjoy a fabulous clinical experience and go on to do other things using their talent and their experience. At the care level, we're talking about care at home. One of the areas, again, to try to attract people into the care profession and be carers is what is, there's a philosophical view, it makes them feel good and so on and so forth. But it is bloody hard work and it's not always appreciated. So we need to find ways, again, I agree with you, track people, reward them, and not always with just a paycheck. All right. I had, one time I had 75 employees and they worked their buns off, pardon my English, French. And I didn't always give them a $100 reward. What I gave them would be a $100 gift certificate to a restaurant that they would never go to, on their own. Take your family out, was it $200? So they got, a certificate at a restaurant, or they got tickets to a show they wanted to go to. That is rewarding people and making them feel appreciated. And it's not traditional, but we do see that a lot. I mean, more and more. We're just not always aware of it. But your point is really well taken, and I appreciate you bringing it up.
Yeah, the idea of stacking credentials, being able to earn things that are not necessarily certificates, but are badges or whatever. I think stacking credentials is a really important topic and one we probably ought to take up sometime. So thank you so
I'm here
much.
to talk about it anytime.
Thank you very much for that. I do appreciate it. And we'll have to leave it at that for today. So I thank both of our presenters for great presentations and look forward to seeing everyone. We'll be combining our November and December meetings into one meeting, and that announcement will come out shortly. So thanks very much.
Thank you. Good to see you. Everybody have a good day.
Bye now.
Thank you, Elizabeth. Thank you, John.
Yeah, thank you, John.
Catch up soon, everyone.